Our scale for the lucid chart is 1 inch equals 10 feet. In the front here, we have the ambulance bay, like walk in. And regular visitors will go through the entrance, which will lead to triage, which will separate our first innovation, separate the emergent and urgent waiting room and the non-urgent waiting room. So that way, the wings are more accessible to those people. The emergent urgent will be faster. The non-urgent can get through theirs faster as well. Now we'll be waiting for urgent people. We have a cath lab, chest pain center, CT scan room, MRI, resurrection bay, 2 treating rooms, staff break room, 2 operating rooms, 4 patient rooms on the emergent urgent side, and 4 patient rooms on the non-urgent waiting side. And in the middle, we have the main hub for nurses and medical communications, with a doctor main hub, like where they do all their work and stuff. And then we have a staff break room near that, in the middle of connecting it all. And we have some desks. And we also have a family consultation room for in the emergent and urgent side. If there's a passing of a loved one, it's there.
So for our 3D model of the ER, we start with the ambulance bay. Coming over here, we have our registration where families and visitors can come in. Coming into this ER room, we have our triage center where patients come from the ambulance and they come here and a triage nurse will assess them for all their needs. They'll classify them into non-urgent, emergent, or urgent. We have crash carts here just in case for medical emergencies. To the left here, we have our urgent and emergent room where we have a waiting room, registration, security. We have a hallway to the other part of the hospital. Coming down over here, we have patient rooms. For example, here we have our updating system, which is one of our innovations, as well as the bed for the patient and treating center for the nurse to come in. To the left here, we also have another way to the main hospital. Coming over here, we have our cath lab for people who have heart issues, so they can get that sorted out. Next to the cath lab is the chest pain center, where people with chest pain can come in and get that checked out. We have the main hub here, where the nurses can monitor the patients through the monitors, as well as they have their own updating system, so they can see and get alerted from the patients. We have another waiting room here. The doctor's lounge is here, so they can do their follow-ups and find a good treatment for the patients. We also have a break room as well, as including beds for people who stay here 24/7 for the staff. Going into the non-urgent room, we have patient rooms similar to the other side, as well as treatment rooms that are specifically for non-urgent patients that need to get treated, and they have priority. Or not, they have priority, but not as much as urgent. We have a resuscitation bay near the ER, so in case anyone is presumed dead, we can have a defibrillator and a crash cart ready, seen by these red cards. Coming over here, we have another way to the hospital, as well as operating rooms, 2 of them, the sinks, so people can go operate, as well as an MRI and a CT machine, so people can get diagnostic tests easier and get treatment faster.
So for the emergent patient scenario, 67-year-old at home notices a sudden and persistent chest pain and shortness of breath and nausea. The patient calls 911, and the paramedics say an ambulance will come to him. So the ambulance arrives at his house and do an EKG on the patient and determine he has arrhythmia and rushes the patient to the ER, which of course is ours. Coming into the ER through the ambulance bay, the patient is rushed through the emergent patient waiting room. To the emergent urgent wing, all the way. Yeah, I was right. All the way. Sorry, I didn't make sure where the cath lab was. All the way to the cath lab. And of course, the hallway, a path is open in the ER for the patient to the cath lab. The patient is found to have a coronary artery disease, which is a blocked and narrow coronary artery. And the cath lab can identify others, like heart valve diseases or peripheral vascular disease. So the patient is put under local anesthesia and is worked on. And the procedures can include diagnostic imaging and pressure measurements, balloon angioplasty, clot extraction, fraction flow reserve measurements, intra-arterial ultrasound, temporary pacemaker insertion, rotational arthrectomy, stent insertion, intra-aortal balloon pump / circulatory assist device insertion, transcatheter aortic valve replacement, and the patient is recovered in 24 hours after being worked on. He's saved, and he would become home within 24 hours and back into their normal routine within a week.
So for an urgent case scenario, we have a 17-year-old patient that was playing a football game and had a massive collision with another player, resulting in a fracture in the humerus. He is transported to the hospital through 911 and ambulance. He comes into the emergency room through the ambulance bay, and he is first checked in through the triage room, where a triage nurse will assess his case and deem it to be an urgent case. So he goes to the left here and gets a patient room where a nurse will come in and take his vitals. After that, the doctor will come in and do a physical exam on the fractured humerus. This is where the doctor will assess the amount of swelling, the bruising, disfigurement, and the pain, as well as figuring out if it's a closed or an open fracture. Since it's a closed fracture, the doctor will ask the teenager to extend and flex the arm as much as possible in order to find if any other bones, tendons, or ligaments are injured as well. The doctor will also ask about the medical and family history, as well as coming into an accurate diagnosis, and recommends the appropriate treatment. Later on, he comes down here to get a CT scan just in case, so they can eliminate if there is any more breaks in the bone, and just in case if there's any more damage to the bone as well. He also goes to the MRI machine where he can get an imaging just in case if they find if it's any more strained ligaments or if there's any torn tissue. So they want to check if any of the surrounding tissue is safe. And since it is safe from all these scans, he comes back to the patient room where the nurse will come treat him with a lot of options. The first would be a coaptation splint with a sling, or a hanging arm case, long arm splint, or a shoulder immobilizer. The teenager chooses a hanging arm case, and he is discharged later that night. The fracture will take at least 4 months to heal.
I'm going to be talking about the emergency room innovations that we chose. So our first innovation is a digital update system on a device in the patient's room that updates the patient on their wait time and condition, which allows for active response from staff and has the messages sent directly to the iPad in the wait room. This is through the program Mobile Text Alerts, which allows for 100,000 messages per month, and it's $899 per month. And it also allows for back and forth texting between medical professionals and the patient when they aren't face-to-face. So this solves problems because it helps patients stay up to date with their visit and condition, and allows nurses and doctors to see patients without ignoring their non-urgent patients. And it allows for fast communication between the patient and the nurse or doctor. So the next innovation are separate waiting rooms for emergent urgent patients and non-urgent patients. They are evaluated with triage after checking in, and the urgent patients are seen quicker, and this helps keeps the patients flowing in and out of the hospital. So the emergent urgent waiting room is more fast-paced, and that side of the ER has more rooms for emergent urgent situations like operating rooms, and the non-urgent waiting room is less stressful, and it allows the doctors to move at a comfortable pace. So this solves problems as seen in the scenarios. They benefited from this, and it allows for organized triage and a much more organized layout of the ER depending on which side of the ER you are on. And this is our reference page.
Our emergency department staff is comprised of 11 different healthcare professionals. We have 6 physicians in order to maximally care and treat for all patients in any case. But at any given time, there may be a few odd empty rooms or patients without a physician in their room. At this time, the physician may be working in the doctor's main hub or attending another patient. But we have 6 nurses and 2 physician's assistants in this time that can care and treat the patient. RNs, which we have 3 of, administer medication and treatments. LPNs provide basic nursing care and deal with patient comfort. The physician assistants and practice medicine alongside the physicians as well as our surgeon, who is capable of handling emergent patients with diseases, injuries, deformities, with invasive or non-invasive surgical methods in operation. In addition, we have a cardiovascular and MRI technician who specialize in cardiovascular tech diagnosing, diagnostic imaging examinations, and magnetic resonance imaging scanning on patients, respectively. These are found in either of the labs, as well as 2 lab technicians who collect samples and perform tests to analyze fluids or tissues of patients. In the front of the hospital, we also have 4 receptionists, 2 in each waiting room, one of which is capable of facilitating and updating the mobile service, while the other focuses on patient care and administration in particular. We also have, towards the front, 4 EMT ready to respond to emergency calls to perform medical services and to transport patients to the hospital via ambulance. We also have administrative services, a care team who is responsible of taking care of patients and their families beyond just medical assistance. They are responsible for assisting discharged patients with anything that they still need after their admission and discharge. They are located in the family consultation rooms for easy access to families during any visit. The total cost is approximately $2.58 million. While this may seem large, this exact number and type of staff is absolutely necessary in order to maximally care for the large number of patients that we can. Given the size of the ER and the 2 innovations that we have, the ratio of worker to patient room is maximized so that all patients may receive treatment within a reasonable amount of time with respect to the degree of emergency of their needs. With respect to the emergency of their needs,